going to be talking more about how psychiatrists can take the lead as part of teams, multidisciplinary teams who are treating people with addictions, as well as what roles we can play in policy, the criminal justice system, with police officers. And we're actually going to talk about a few models in particular that Ellie and I have been working on that we'd want to tell you guys about. So
what we're hoping to do is kind of go beyond what everyone here already knows, beyond the medical model of addictions, meaning we all know how to treat addictions, but what's interesting to us is why psychiatrists are well positioned to collaborate with other specialists, other doctors, people in police, and what can be done to actually have effective results that are more than just theoretical talk.
And looking at different models to do that with. So we're going to talk about specific models that are out there, like there's the hub and spoke model. Ellie's been doing a lot of research on the sequential intercept model. And we also are going to talk about public policy and how psychiatrists can help shift the paradigm of addictions and how people deal with addictions in the community.
Right. So one thing that's been interesting to us is what keeps addictions going is bad outcome happenings, making sure that another bad outcome is going to follow. So when you have a relapse, you're more likely to have a relapse. When you engage in criminal behavior, you're more likely to engage in criminal behavior in the future. So we're looking at interventions that can address the needs of this addicted population to reduce criminal recidivism and most importantly also save lives, because if the patients are dead, we can't do anything for them.
Yeah, and we really think that psychiatrists, we need to encourage each other and support each other in owning addictions as a psychiatric disorder and something that we are capable of treating. It's kind of shifting our mentality from one of exclusion of people with substance use disorders to inclusion of people with substance use disorders as patients in our clinics.
And one of the problems now is that when policymakers are trying to think of policies that will help and that will try to solve the opioid epidemic, what they think about is recreational drug use, and they just assume that addiction is just that on steroids. It's like a big version of recreational drug use. And the problem there is it's simply not. It's a different beast, and people have different attitudes. So the way to do that is really to shift the paradigm, how the general public thinks of addictions, instead of thinking that these are either sick people, junkies, or all these things that you hear, or the opposite, which is like, these are people who are weak, have no ability to do anything, and we need to take care of them, and kind of look at them as people with conditions that deserve to be treated fairly. And once the public thinks differently, the elected officials will create laws that reflect what the public thinks.
So we just want to empower psychiatrists to take the lead. We want to empower psychiatrists to feel that they already have the knowledge base to do what needs to be done, and to just show them, to put out there different ways that we can brainstorm together to do that. So we're really excited. We reached out to law enforcement officials and asked them how we could work together to help them better serve the communities they live in and better deal with addictions and other mental illnesses and recognizing them and treating them and being the first responders in them. And we are putting together an online training module actually that addresses different mental illnesses. Substance use disorders are part of them, racial biases, disparities that officers face, and help them address them. And the APA is actually helping us with that. They've been very generous with resources, and that's one of the projects we're working on, and then we're going to present. And another one.
And actually, one more thing on that thing, the models that police officers use now are based on disease, so they're taught about this is what schizophrenia is, this is what depression is, and they don't, when we talk to them, we don't really care to know what's the difference between schizophrenia and schizoaffective disorder. We need to know what we're seeing on the street. Is this something that needs to be taken to a medical emergency room? Is it something that needs to be taken to a psychiatric emergency room? So the curriculum that we're working on is going to be symptom-based, and it's going to be online to address a lot of the financial problems that keep a lot of these the agencies from getting the training. The other project we're working on is we're trying to adapt a model that's called the SIM, the sequential intercept model. And the SIM was a model that was developed initially for psychiatry in general, how to keep people with mental illness outside of the criminal justice system by looking at every stage of the arrest, incarceration, pre-arraignment, post-arraignment, pre-release, post-release, and every step is an opportunity to intercept people with mental illness and provide them with interventions. Right now we're developing an adaptation of this model for addiction specifically, so that we're looking at the interventions that apply to addictions that reduce criminal recidivism.
And what we're going to also focus on is where psychiatrists can fit in that as experts in both mental health and addiction. So, using our expertise at every level of the way to inform the process and hopefully help shift the thoughts that people have about addictions and people in the criminal justice system to one of treatment, rehabilitation,